Hi, my name's Adam, and my pronouns are he, him.
And hello, I'm Emily. My pronouns are she, her.
We're both ST3s currently working in Oldham, and today we're going to talk to you a little bit about trans and non-binary health and kind of the easy wins that we can do to try and make things better for trans and non-binary people.
So Laura's just touched on this, but please ask questions. We are going to do questions at the end because it's a little bit of a whistle-stop tour, but there aren't any stupid ones. So please ask if you want clarification about something that we're talking about. There'll be a really wide range of experience, both personal and professional in the room, but try and use the correct language where possible. But obviously mistakes are natural. We make them all the time. So it's all for kind of shared learning. And hopefully this is a safe space where you can ask the questions you weren't quite sure about.
So today, as we've said on the front, we're going to talk about trans health. We're going to kind of cover why it's important and why we need to be thinking about trans healthcare and improving things for trans communities. We'll talk about the easy ways in which we can make things better and kind of some stuff about general healthcare stuff that we need to think about with trans and non-binary people. What we're not going to cover today is essentially children, because that's really, really complicated, and we're not going to open that can of worms today. We're also not going to talk about kind of specifics in local pathways and things and kind of specifics about hormone prescribing, because we could talk for ages and ages on that. So why is trans healthcare important? I just want to kind of open it up and see what people think about why it might be important that we think about it. Yeah. Yeah. Mm-hmm. Anybody else? Yeah, absolutely. Yeah. And
I think also because it's something which is actively suppressed or marginalized by other groups. So I think that means that as practitioners we need to take an extra step to make sure that everybody gets equitable access.
yeah.
Lovely.
And that's the key there is equity. So it's, you know, everybody has the right to healthcare, but it's the thing of we can provide things the same, but that doesn't work for people that are disadvantaged in the first place. So we need to try and do extra to bring them up to the level of the general population. So if we think about trans people, they can have very difficult lives right from, you know, when they're born. People can be aware of their gender identity at a young age. And we find that trans people and LGBT plus people in general, they're more likely to be kind of bullied at school. They might have problems with their family. They might be disowned by their family for their gender identity. They might be subject to discrimination in the street or at events. They might be discriminated against at school. They may have had bad experiences of healthcare services. And it might not be things that we're purposefully doing, but it might be things, you know, with the throwaway comment or the fact there's not a gender-neutral toilet and things that put people off accessing healthcare. Lots of misinformation in the media at the moment. I mean, there's lots of stuff going on in America with kind of issues about toilets and drag queens and all that sort of stuff that's becoming a big issue there. And they're more likely to have experienced kind of physical violence, sexual assaults, difficulty accessing good quality housing because they'll get discriminated against for that, and also with employment as well. So that then leads to financial difficulties, which adds to kind of the social deprivation. And that's too small for me to read at the back there. But you see, there's loads of statistics here, and it's just terrible for trans people. They have essentially worse health outcomes in every single way that you can think of. They're more likely to die early, they're more likely to have long-term chronic diseases and increased morbidity. They're more likely to smoke, more likely to drink dangerous amounts of alcohol. And it's when it's compounded with all the other things as well. So if you're trans and black, if you're trans and black and disabled, all those kind of inequalities add on top of each other to make things more difficult.
And just thinking, as we have done all day, about the deprivation, if you then add deprivation onto that, the accumulated health inequalities you would experience as an individual are enormous. So, on a more positive note, are there things that you guys are already doing? We'd love to hear about anything that you think you're doing in your practice that's particularly trans-friendly. There could be anything tiny to anything big. We've got some ideas, so don't worry if there's deathly silence, we'll bring up our ones. But is anyone doing stuff already? We'd love to hear about it. Either in practices or in community teams or in third sector organisations, anything that you guys have seen.
We've been doing questions involving people that access the service, and it's to see if we have female projects for them, male ones for them, but it's like how we feel about this person on the side, or how, because society needs to change, doesn't it, you know what I mean, we need to start then, and how it feels like in a female, for the level of protection from domestic violence, how it feels to have, you know, the opposite sex come in as a gender, you know, so it's trying to start a question to find out how we're starting to move forward, so, you know, it's good that we're asking questions and starting to learn.
Lovely. Any others in the room? Yes?
We became a private practice, and so I guess it was about changing some things on our forms, and we fill them in at the beginning, but then also making sure we've got a kind of big board that's kind of more welcoming, if you like, where everyone's welcome here. So if you wait in the waiting room, you know that this practice is inclusive, and we're aware, and it's not just like, oh, you know, you just, you know, we're consciously making an effort to make people feel comfortable.
Yeah, lovely. So for any trainees in the room, it's a very quick win and a good QI project. Have a look at your registration form. Are you looking at gender? Are you looking at people's gender identity when they register at your practice? All of the Hope Citadel practices have gender identity on the registration form, and then coding them on EMIS. And Adam's going to talk in a little bit about, we can't talk about trans healthcare if we don't know who our trans patients are. So that's one really important thing, and that kind of links back to, I think, the first speaker of the day was talking about data and how important the data is. So some things that we came up with was to do with education of staff and thinking about terminology, using the right terminology where possible, and we'll talk a little bit about that. We'll talk a bit about how in your practice you can create trans-friendly practice systems that, as Dr. Reader said, the minute someone walks into the door, do they think they're in a place which is safe and inclusive? And I think Jeff mentioned it earlier, you can have the best GP in the world, but actually we're the last person they see. So it's about the people who they're seeing first. It's about the people on the phone. It's about walking and sitting in the waiting room, and what do you see when you're in the waiting room? And then again, so staff awareness and training. So just touching on terminology. So this is our wonderful gender-bred person. Some of you guys have seen this before, and some may find it quite basic, and that's fine. I don't apologise for going over the basics again. So thinking about going right back down to it, when we're talking about the terminology in trans healthcare, getting this right is really important, because the language we use creates the tone for that interaction with that individual. So if you're able to understand the difference between gender identity, gender expression, how that then links or doesn't link to their biological sex, and how that's completely separate from sexual orientation, then that's a really good place to start. And we'll get this circulated afterwards so you can have a little look at it. While we've just got that up, does anyone have, I won't go through it in loads and loads of detail, but does anyone have any questions about that? No? Lovely. So thinking about trans-friendly practice systems, so Claire mentioned something earlier, so about having a queer board up in your waiting room. If patients or people can sit there and see that you've thought about them as individuals, then they're far more likely to open up and engage in healthcare about any aspect of their healthcare, be it to do with their trans status or not. I think Monica mentioned it about gender-neutral toilets, so providing a space where that individual feels that they can go to the toilet in your practice is really important where possible. I know that's not always feasible, and gender separate toilets are also important, but if you're able to provide that, then that's really great.
Just make sure your staff are trained as well. So things like the Pride in Practice scheme are great, because, as we say, it's not just us as clinicians that need to know this stuff. It's your reception staff, and educating them on using the right pronouns and make sure they're not misnaming and gendering people, and things like name badges with pronouns on. You can see a lot of people wearing rainbow badges and things. The important thing, I think, with rainbow badges is not to just give them out willy-nilly to all your staff. They should only be going to staff that have had the appropriate training and are happy to discuss all aspects of LGBT care. So I think that badge is a sign for someone that this person is okay to ask about this thing. But if you don't feel comfortable or have the knowledge to talk about trans issues and stuff, it's probably not a good idea to be kind of wearing that badge or rainbow.
Thinking about your resources, can you have a section on your practice website that can direct patients if they're not sure? The LGBT Foundation has a massive array of resources, both national and in your local area, which individuals can find really helpful, because that community support is going to be really important.
So one of the most important things is just knowing who your trans patients are, because we could have all the goodwill in the world, but if we don't know who our trans patients are, we're not going to be able to kind of target interventions and do things to help improve their health. So it's important that we're asking people, and the best opportunity to do that is on your practice registration forms. You can have the question there, and there's lots of guidance you can find online about how to ask those questions. And the LGBT Foundation produces a document called If We're Not Counted, We Don't Count. And that has some great guidance for how you can implement not only trans status monitoring, but sexual health monitoring into your kind of practice. And making sure that you document that on a system where it can be found. Because if we don't code it properly, that means if you do a search on EMIS, you're not going to find your trans patients. So you need to make sure that that's being coded appropriately. Also, I've lost my train of thought now. Making sure your records are up to date. So you can check with new patients coming in, but you may have had patients there that you've not asked these questions to. So it's just about being opportunistic when people are coming in for other issues, if they're, asking people about their trans status, if it's relevant to the consultation, or sometimes even just sending out a text like you would do to ask if people are smoking. It might just be sending out a text questionnaire just to, update your records about people's gender identity and sexual orientation. So just a little bit onto kind of referral and what we can do for trans patients. I think that the headline is just to refer early. My view is if somebody comes in and discloses to you that they're trans or perhaps questioning their gender identity, I think one of our first questions should be, would you like a referral? And getting that in early, because it's not our place, the services set up, it's not our place to judge and be barriers to people accessing gender affirming care. Even if you think, oh, well, they might have a mental health condition or whatever, if they've come in and disclosed that to you, we should be offering a referral early on. Because the waiting lists are huge as well. I checked this again only the other week. I think the waiting list for Leeds is somewhere around 30 months at the moment. And that's pretty average across the UK. You're looking at least like a 20-month wait to have your first appointment in a gender identity clinic. And obviously that's a long wait, so we need to think about what we can do in the meantime for people whilst they're waiting on these long lists. And there's lots of services that we can access to support people. So you might want to access psychological therapies, which are available through the LGBT Foundation, which is national, so it's not just a Greater Manchester thing, that can be accessed across the country. You also think about whether people might want speech and language therapy so that they can try and coach their voice to present in their identified gender. Also thinking about gamete storage as well, because even though somebody's transgender, they may still wish to have biological children at some point in the future. And that's something that is funded on the NHS. So, and they generally get seen quite quickly as well. So getting in a gamete storage referral it would be St Mary's, kind of in the northwest region, to get that in is important as well.
And just thinking, Adam touched on it there with the psychological therapies, but thinking about mental health, so not every problem is a trans problem. So thinking about patients' mental health on an individualised level and not being afraid to treat kind of comorbid conditions. So there's really high rates of depression, anxiety, there's high rates of eating disorders, there's high rates of pretty much every mental health condition we can think of amongst the trans community. So addressing those, making it clear that you're not saying that this is a mental health issue, but that you're treating it alongside the pain that they're experiencing. I've put up some of the risk factors, but I won't go through those in loads of detail. But I think it's just about not being afraid to explore their mental health and acknowledging that what they're going through could be psychologically distressing, and it's really hard being a trans person.
Screening is a big one for promoting health in our trans patients and can be something that can be quite difficult to navigate. So I have a handy little guide, and it's all about what bits and bobs they have. So at some point we have to talk about genitals. Obviously in most consultations that's not going to be appropriate and would be a bit intrusive. But in terms of screening, so this might be a conversation you have when somebody first joins the practice, to have a sensitive conversation about whether they still have a cervix, because if somebody has surgery, they might not necessarily take out all their gender-specific organs. So some people might still have a cervix, they might still have ovaries. When men, if a trans woman has had gender-affirming surgery to kind of remove male genitalia, and they'll usually leave the prostate behind. So it's important to ask. So we can see the handy diagram. So if they've got a cervix, they get cervical screening. Simple. You have to kind of make your own process of picking those people up, because if they're coded on your EMIS system as male, and they won't automatically get picked up by the screening program at present, but there are new processes being brought into place to address that. So it might be to keep in a spreadsheet or something of people with cervixes so that you know that they need to be brought for screening. Breast screening can happen for both trans women and trans men, even if they've had a mastectomy, because there may still be breast tissue left behind. Aortic abdominal screening, we don't know on that one, but essentially it's available for anyone if they want it in this situation, because it's blurry as to the evidence of how much kind of hormones change your risk of aortic aneurysm. Definitely if you've got a trans woman, you still want to be screening them, because actually most of the risk is probably genetic related due to chromosomes. But trans men, you could refer them in for screening as well. And then obviously bowel screening, hopefully everybody's got a bowel. There might be a couple of people that have had it chopped out or something, but they still need bowel screening as well. And then just kind of a note on things like cardiovascular screening and fracture risk and stuff. Again, it's really tricky because there's not much research in trans people. So it's difficult to say, you know, do we put them as a man or a woman on the form, because it significantly affects their risk. I think some consensus is that if someone's been on hormones for around 10 years, then they probably have the risk profile of their affirmed gender, but it's not a given. I think my pragmatic approach would be to always go for what's going to give you the highest risk. So if you think about the treatments that you're giving, especially for cardiovascular disease like statins, they're pretty low risk. So actually you're probably going to get better benefit by overestimating the risk and kind of catching everybody rather than being unsure and underestimating it and missing people.
So that was our quick tour. So if anybody has any questions, then please, I don't know how long we've got left. If we've got 2 minutes for questions, Sam's saying. deathly silence.
Everybody been stunned into silence. Yeah. So, EMIS codes are fraught with trepidation. Because if you try and type them in, you'll get all sorts of stuff come up, including transsexual and all sorts, which are just, they need to be deleted. You can code transgender. Now, you just need to be careful that you seek the person's permission before you put a transgender code on their record, because it's a protected characteristic. And then if you start generating referrals, if it's on a problem list, that's automatically kind of going to get copied onto your referral. Most people are probably going to be fine with it, but you need to check with them first. And then what I tend to do is then free type next to that problem, just to be like, you know, if I've asked them, you know, but they still have all the female organs or whatever, just so it's easier then someone sees them again, that all that information's just there in an easy to find place and it's not need to be asked again. You can also add alerts and things as well. So if they call for an appointment, you can have an alert pop up just to say, like, you know, make sure you use male pronouns, etc.
And just on that note, thinking about NHS app and who has access to their app. So for example, if you're seeing a younger person who perhaps you're the first person they've told, being aware of what can be seen and who has access to their kind of app online. So just having a conversation about that, or making it the online visibility thing off if they're not happy for other people to see it, or if other people have access to their app.
For trans men, if they've had, I think you mentioned that they leave their screening, but what about the trans women? If the man has not had any hormones, then they don't have, do they still need the screening?
So there's no clear answer. I think generally with trans women, they're free to have screening if they wish. See, if they're having hormones and have started to develop breasts, then absolutely they should be having breast screening. But as well, it's kind of just part of the experience of living life in your affirmed gender, is that breast screening is something that women have, and some people who are trans women will want to go and have that as part of their kind of affirming experience, that, you know, I'm doing everything else that a cisgendered woman would do. I just say as well, changing names on records. Please don't be afraid of changing people's names and stuff. They don't need any paperwork for you to change their name on the medical record. Changing gender is a little bit more tricky, but there is a process for that. And you can find that on the Gender Toolkit, which you can Google online, which is produced by a group of organisations in Greater Manchester. Yes, so that's only if you're changing their gender. So changing name, you can do that without any paperwork. It's quite easy to do. With gender, you have to submit forms to PCSE in order to obtain a new NHS number, and then you've got to kind of summarise the record and merge it into the new record, and they exist as a completely new person at that point. As many times as you want.
Change it back.
Yeah.
Or you can have a preferred name as well. That's the other thing. There's lots of like old Ethels who like to be called Margaret, isn't there? It's no different adding on a preferred name for somebody. But having that conversation about whether they want their name changed on it is absolutely fine. And you can do it as many times as you like on their EMIS.
In case of chaperone, like, what would you offer if the patient asks for a chance?
So ask them. So my advice would be, so with chaperones, if you're doing an examination, offer a chaperone, and if they say yes, offer a chaperone and ask them what gender they'd prefer that chaperone to be.
If not available, then we can change the appointment, or what we do?
I think it's just as you'd
Same
approach it with any other patient, isn't it? If you were doing an internet examination on a cisgendered woman and there wasn't they wished to have a female chaperone and there was nobody around that day, then you'd offer to postpone that examination, wouldn't you, until there's somebody available. So it's just the same with trans people. If you can't, provide what they want to have that examination done comfortably, then we make arrangements for it to be done when that can be facilitated.
The other note on examination is that obviously intimate examinations can be quite painful, particularly if somebody's, for example, a trans man who's been on testosterone therapy. So actually that could be quite a good opportunity to talk about in preparation for our next appointment, using something like a moisturiser or even topical vaginal estrogen prior to that appointment can be really helpful to help reduce some of the pain, and the kind of level that you're going to get from vaginal estrogen is not going to impact or affect their gender-affirming therapy that they're already on. So sometimes that could be quite a useful thing to have that slight gap, as long as it's not clinically urgent, obviously.
Thank you very much.
Thank you.
And we will be around as well if anybody does want to ask any other questions, including hormones and all that sort of stuff. Thank you very much.